Okay, on now to the presentation. Now the presentation is going to be divided into a few different subsections, but we thought before we start with any of those, just a few general tips. Now these have been taken from some standard textbooks that you can find on clinical examinations. One of the things that's been mentioned in more than one place is the importance of actually watching yourself on video. So stepping out of your own persona and looking at how you would actually be viewed by the examiner or other observers. So watching yourself on video, you should be able to pick up a few different things. You should observe your general posture and your body language and make sure that you're not appearing to be too slouched, that you're sitting up straight and actually appearing professional to the examiner. And also other aspects of your body language, if you fidget too much, you should be able to pick that up. And one of the tips that that could be given to help someone who fidgets too much is maybe just hold on to your pen or your paper just to make sure that they don't start wandering around. Another thing is to actually observe the speed at which you talk, because talking too fast in particular can come across quite awkwardly and maybe perceived by the examiner to be due to nerves or a lack of confidence. So just make sure that the speed at which you talk is at a suitable pace for you to appear confident and professional. Now on to the summarising statement, which is the first and possibly the most important part, in the sense that it actually sets the stage for the rest of the presentation. And we all know that first impressions count. So looking to the ISCE pack, we see that in order to get a satisfactory mark in the summarising statement, it needs to have precise and relevant details. Ideally it should be a single sentence, and an unsatisfactory would be awarded to someone whose summarising sentence was rambling, it was unfocused, or it was too long. Now, the BMA give a few pointers on what one should include in the summarising statement, and this is generally accepted across the board, plus or minus some few details. They suggest that, and obviously one needs to give the name and some brief descriptions, so age, sex, and possibly even any chronic conditions, especially if they're relevant to the actual presentation. Next, one should mention the main presenting complaint and also the duration. So for example, a man who has come in, a 42-year-old gentleman who's come in with a 2-year history of exertional dyspnea. This, as I mentioned, gives the examiner a snapshot of the story to come, and its purpose is to give him or her, give the examiner some idea of what the differential should be. So they will actually start thinking in their mind what the differential should be from now on. So on now to the differential diagnosis. The ISCE pack mentions that the differential should be succinct, and it should have an appropriate ranking, and it shouldn't be too broad, and at the same time shouldn't be too narrow. Take a look at this next clip.
This is a 69-year-old diabetic lady who has a 30-pack-year history of smoking and previous episodes of acute coronary syndromes. Is presented today with a 2-week history of shortness of breath that was brought on by exertion and lying flat.
Okay, so now just run me through your differentials, please.
So, myocardial infarction, angina, could be pneumonia as well, and then you can have lung cancer and heart failure.
Okay, anything else at all we haven't mentioned?
Anemia. Anemia? Yeah, anemia can cause shortness of breath too.
Right, okay, so now just run me through the causes of anemia relevant to this patient.
Sickle cell, but she's not that.
Unlikely, but what's relevant?
You can get normocytic, macrocytic, microcytic, so thalassemia, it's not going to be thalassemia. Iron deficiency, anemia, and anemia of chronic disease that can cause shortness of breath too.
Now most would recognise that this student was thinking or rather brainstorming as he was going along. Now all of this should have been considered when he was taking the history. The question should have been focused in order to help him rank the differentials according to what was most likely and going down to what was least likely. Further to this, basic patient information should have been enough to give some sort of idea of the ranking. So for example, malignancy wouldn't have been considered for a 16-year-old, for example. Now going on to the positive aspects, the student obviously had knowledge on different causes of this particular presentation, and this was coming out as he was going along, but because of the fact that he was unprepared, he was very unfocused in his differential diagnosis.
Okay, so my initial thoughts would be to consider either respiratory or cardiovascular, or perhaps another cause. Considering a history of coronary heart disease, it's possible that this is a new onset of coronary artery disease after her previous stents. It could also be the development of heart failure secondary to her ischemic heart disease. And then coming on to respiratory, I know she's not pyrexial, but we should still exclude common things such as chest infection and even a pulmonary emboli, or embolus even. Because of her age and smoking history and associated fatigue, I would also query anemia secondary to some sort of malignancy. But at the top of my list would be heart failure, because of a past medical history and current symptoms suggestive of pulmonary edema. But this is with the proviso that new onset angina, infection, or malignancy have to be ruled out, and an embolus may go further down due to the absence of any uniquely discriminating factors.
So this is what some of the examiners mentioned. One of them said that you should give more than just 2 or 3 causes. One should give a slightly longer list, perhaps 5 differential diagnoses. Some of them said that examiners would also be particularly impressed if one tried to categorize them into different categories. For example, if we take stridor as a presenting complaint, we could divide it into congenital, and the example one would give for that would be laryngomalacia. And then you could go on to infective or inflammatory causes, and one could include epiglottitis within this. And then you could go on to mention a malignant cause and give laryngeal carcinoma as the example for that, and so on and so forth. And there are several mnemonics that one can learn in order to help them remember the different categories or different types of etiologies. And one of them, one of the longer ones, is divine hati. This stands for degenerative, infective, vascular, iatrogenic, neoplastic, endocrine, hereditary, autoimmune, traumatic, toxins, and idiopathic. And there are several other categories that do exist as well. One particularly surgical way would be to base this on anatomical differences. So if you take the example of small bowel obstruction, you could think of it in terms of a luminal cause, an intraluminal cause, and an extraluminal cause. Now, in this example that was given, the student gave a hunch at the end of his differential diagnosis. One of the examiners supported this and stated that students should go on to hedge their bets. After having given a list of possible causes, one should actually then stick their neck out and try and go for a differential, obviously based on clinical reasoning. Others also stated that it may be a good idea also to include a list of possible differentials that are not likely. Now, this may also show clinical reasoning. You're showing why this particular presentation is not due to such and such. It's not due to malignancy because of the patient's age, because of the absence of any other features, and so on and so forth.